Dear friends and colleagues, I'm Eva Garmendia, coordinator of the Uppsala Antibiotic Center, and I would like to give you a very warm welcome on behalf of Uppsala University. Thank you all for joining us, either here on site, online, or perhaps later as a replay. Uppsala University has had a long interest in supporting work around antibiotics and antibiotic resistance, and today is currently involved in a big array of consortia and international projects such as REACT, Action on Antibiotic Resistance, which is an international network working with advocacy and global engagement, the Uppsala Antibiotic Center, where I work, which is a multidisciplinary center for education, innovation, research, and awareness, Enable2, an antibacterial drug discovery platform with focus on early stages of antibiotic drug discovery and development, and Platinea, a platform for innovation on existing antibiotics, among many, many other projects. Today, we are meeting here to discuss a very relevant question. Is it possible to apply the experience that Sweden has working with antibiotics to other places around the world? Due to the international nature of this very question, as well as our panel here today, we are going to have this seminar in English, as you can see, so many more can benefit from this occasion. Without further ado, I would like to introduce you to our moderator today. It's not going to be me, Anna Sjöblom. Anna is a registered nurse on global health and is a specialist who has worked in humanitarian fields within infectious diseases, advocacy, and policy for 20 years. During her times at Médecins Sans Frontières, she worked with outbreaks of acute malnutrition, pediatrics with access to vaccines, and essential medicines. She has also worked at the Center for Research on Healthcare in Disasters at Karolinska Institute and within the Swedish healthcare sector. That's a very, very good CV, Anna. Currently, Anna is the director of REACT Europe, and is going to take us today through this very interesting conversation. So thank you, Anna, so much. The floor is completely yours.
Thank you, Eva. And again, welcome everyone in the room here in Almedalen, Visby, and everyone online. Next year, the United Nations will host the second high-level meeting on the crisis on antibiotic resistance ever. And during this meeting, we need very bold commitments to address this crisis that are today killing more people than HIV and malaria in the world. But it's also a problem that undermines healthcare systems as we know it. Sweden has started early and has an extensive experience in working cross-sectionally in addressing this issue from human health, animal health, and environment side. And today there's an inter-agency group created already back in 2012 that is gathering both public agencies and other organizations. Sweden also has the STRAMA group that we'll hear more about today in a minute, the Swedish Strategic Program Against Antibiotic Resistance, which is been an important success for Sweden. We're here as part of the REACT network and Uppsala University that has worked with this issue since 2005. And this year, together with the Public Health Agency, we worked in creating an e-learning module on the STRAMA model of working. But the question remains, can this experience been transmitted to other contexts? And what different realities exist out there when it comes to tackling ABR within the healthcare sector? What does it look like on local level in primary healthcare structures in Zambia, for example, or in hospitals in Nepal? we work with in React Network to bridge between science and policy, but we're also advocating for stronger action on antibiotic resistance, both globally, regionally, and on local level. So we support and work in low and middle income countries to implement national action plans. We work in India, Ecuador, Zambia, Kenya, and other places, both with communities and within the healthcare sector. And we'll hear a little bit more about this very soon. So, but I'm also sure that Sweden has things to learn from other countries, which we will also address. So during this coming 45 minutes, we will explore this together with the panel and also make room for some questions from the audience in the end. So here today, I'm very happy to introduce the panel, where we have here in the room Jakob Altgärde, an infectious disease doctor with a long experience, but that already during your studies actually traveled to work in Nepal, in the United Missions Hospital in Tansen. But your job, you're also working in Region Jönköping in the infectious disease department there. We also have here Malin Grape, who's a doctor in pharmacology and a background working with EMA with the public health agency in Sweden, but also in many international projects with exchanges between Sweden and other countries. And since February last year, you are the Sweden's ambassador for the work against AMR. So welcome to you. And also online, we have Dr. Murphy Mupundu, who's also a pharmacologist and a specialist in doctor in public health, who has worked a lot with supply chain management, but also on global health security, international health, policy, and diplomacy. And you're also the director of one of React's 5 nodes in Director of React Africa, running programs both on local level and also a lot of policy work and supported many countries in Africa with the national action plans. And we have Thomas Tengdén, who's also an infectious disease clinician and an associate professor at the Department of Medical Sciences here at Uppsala University. And you're also the chair of the Swedish Estrama. So welcome to you all. And I will start with you, Jakob, with an outlook on the situation of antibiotic resistance in a country that we don't hear so much about when we talk about this global crisis. So you're recently now back in Sweden after working 2 years in Nepal in a hospital setting. Can you tell us a little bit, like paint the picture of the situation in Nepal when it comes to resistant bacteria and how affected the country is, as well as the healthcare system? And maybe also touch upon what is being done at local and governmental level.
Yes, thank you so much. So there is antimicrobial resistance is a tremendous challenge in South Asia, including Nepal. And probably the situation there is worse than anywhere else. In Nepal, there has been unregulated antibiotic use in agriculture, where antibiotics has been used not only to treat sick animals, but actually also for growth promotion. Over-the-counter sale of antibiotics without prescription is very common. It's actually the standard access point for antibiotics. The widespread access of antibiotics might have saved lives of children with pneumonia in rural parts of the country where there is no doctor near. But it also leads to massive overconsumption of antibiotics. Inadequate dosing, inadequate length of treatment. I myself have been offered broad spectrum 3rd generation cephalosporins on the street in Kathmandu in a pharmacy just by asking for it. Not only pills, even injectables, and I didn't even have to mention that I had any symptoms. People are buying antibiotics for simple self-limiting viral infections and are doing so without a prescription. And the infectious disease control measures in the country is limited. Many studies in Nepal are showing high-level resistance in key pathogens, which of course leave us with limited, expensive second and third line antibiotic options as the only options we can treat the patients with. There are positive actions taken in Nepal, and I would like to mention two that are taken to decrease the impact of AMR. The first one would be that Nepal launched an ambitious action plan on AMR in 2016, including, for instance, a ban on antibiotics for growth promotion in animals. In the action plan, there's also a goal to restrict over-the-counter sale of antibiotics. Now, 7 years later, after the action plan was written, is there a gap between the action plan goals and what has been put into practice? Well, I'm sure there is more work to be done to achieve the goals. That was the first thing. The second thing would be surveillance, which is done of resistance to antibiotics and reported from over 20 microbiology labs all over the country. The data is compiled and reported to the National Health Laboratory in Kathmandu and then submitted into the WHO GLAS AMR platform. And there are more actions taken as well, but I would say these are probably the two most important ones.
And when you were working in Nepal, in the hospital, what would you say were the biggest difference from your work as an infectious diseases here?
So I've been working in a rural, busy 165-bed hospital on the Nepali countryside, about 1 day's travel from Kathmandu. And I've been working there for the last 2 years as a medical doctor. I've been involved in critically ill patients, other inpatients, but also in the outpatient setting. And I've been in the microbiology lab, done some work there, and also teaching doctors about antibiotic stewardship. In the hospital there is basic hospital hygiene practice in place, but it would be quite different from what's in place in Sweden. I have a good cause to believe that antibiotics are used relatively rational in that hospital due to internal hospital guidelines. Yet even then, antibiotics are often prescribed unnecessarily. And often too much broad-spectrum antibiotics are used. There are reasons for that. In case, for example, and that's a few differences from Sweden. We have very limited diagnostic tests in that setting. There might be fear of treatment failure among doctors. And if the patient deteriorates, then there are a lack of ICU beds, which is also a difference from here. And the lack of relevant local microbiology reports lead to difficulties in changing from the initial adequate broad spectrum antibiotic that we're using for the patients to a more narrow spectrum specific antibiotic.
Okay. Thank you very much for that good explanation on the situation and also what the positive developments at some points as well. So now I turn to you, Thomas. So you also working on a daily basis in an infectious disease ward in Uppsala, but you also since several years chairing the Strama network, the regional Strama. So can you explain just in a couple of sentences what that is? What is unique as you see it with Strama and what's the strength about it?
Okay, hi everyone. So Strama is a network of healthcare professionals that was started in the 1990s, but by a few individuals who realized that we need to do something about antimicrobial resistance, and we need to do that by reducing unnecessary consumption of antibiotics and uses that's restrictive as we possibly can without harming the patients. And today we have more than 20 regional groups, so it's integrated, you can say, in the Swedish healthcare system. And we also have a national coordinating group that tries to sort of provide tools for the regional groups to do their work. So we provide treatment guidelines, we work on more strategic issues, we organize education and networks meetings and things like that.
And I've been here in Almedalen a couple of days now, and I listened to part of several discussions on antibiotic resistance work in Sweden, and we come back to how well we are working with this and the strength of this. But I mean, I just have to ask you, are we still best in class? Or are there also aspects where you think of, okay, adapting a system of Sweden to other places that you may be less proud about?
Okay, yeah. I think other countries are definitely catching up, which is a good thing. But we still do a quite good job, I think, in comparison to others. But of course, we always try to be better. We try to, for example, go as close as possible to the prescribing situation to try to give individualized feedback and advice to prescribers. So I think, like I said, it's a bottom-up initiative and it's very well integrated in the healthcare system. We have been working mainly with educational activities, meaning that we believe that as long as the prescribers are well informed and they make decisions in the interest of the patients and no other incentives, they will make the right decisions and use antibiotics restrictively and correctly. I think in other countries, maybe the healthcare system is very different. You have another kind of resources, and maybe there are other incentives that will impact your prescribing patterns. And then perhaps you need more restrictive measures, I can imagine, than we do in Sweden. So I think we have a very good way of reaching prescribers. They get education on resistance and rational use already in medical training. So they're quite well informed, which I think is a great advantage.
Thank you. And I think this is a very good bridge over to you, Murfin, who's for several years now have been working with your team. You've been very much involved in, I don't know if it's like up to 15 countries in the region now or even more, in supporting the actual implementation of the national action plans, and within that part that is linking to stewardship on hospital levels and so. Although it's very difficult to generalize, of course, when you talk about a whole continent, but from your side, can you give us a couple of examples of how that work has been, developing, maybe like some of the challenges and that you've seen in this work?
Yeah. Thank you so much, and thank you for really having me. I think when we take a step back to 2015, when the World Health Assembly adopted the Global Action Plan that gave countries 2 years to develop national action plans. Most countries began that process. When that process began, there was no template, there was no further guidance, except the 5 strategic goals. One that focuses on raising awareness and knowledge around antimicrobial resistance. Number 2, really focused on really surveillance, getting to know what sort of pathogens that we have. The 3rd strategic goal was to really strengthen infection prevention and control. The 4th one really focused on, better utilization of actually antimicrobials that we have. And lastly, it was making a case in terms of investment in research and development. And so we supported countries, develop plans around those 5 strategic goals. We provided technical capacity, and in some of the countries, we also provided financial support in terms of developing those plans. By 2017, a number of countries had actually developed those plans, and now in the African region, we've got 39 countries that have got plans. But that means that there are some countries that don't have actually plans. Some of the earlier challenges that we had was that a number of countries did not have any financial capacity and capability of developing the plans. And so they depended on, on organizations like REACT and other organizations to actually, support them in that process. So what that has led to is that, the National Action Plan's implementation in countries have not moved as fast as they should have moved. And fundamentally, there has been, a lack of political will that translates into investments into health systems. The health systems are weak. The picture that was painted of Nepal is no different from what we see in most African countries. We face some stockouts of, basic essential antibiotics. We have weak laboratory infrastructure. Most times that clinicians have to shoot in the dark by using broad spectrum antibiotics. We've got over-the-cells, we have over-the-counter cells, legal systems are weak, and regulatory systems to actually enforce existing laws. There is the challenge of actually understanding really AMR in the cultural context and the way that it actually impacts on different groups like gender. We have a really overconsumption of antimicrobials in the animal, sector, as growth promoters, as mentioned earlier. That is used a lot in poultry in most of our countries. There is also the lack of coordination, realizing that really AMR affects both the human, animal, and the environmental sectors, and that leadership at country level is actually lacking. And of course, lastly, among the challenges, it's the fact that, there's just easy access to, really a few molecules, including injectables, that one can be able to procure from anywhere and use. And so these are some of the challenges that are there in terms of really moving forward with addressing antimicrobial resistance in low and middle income countries. Thank you.
Thank you, Marfin, for describing that process also from 2015 and today, and also, but because what Thomas also mentioned about the involvement of healthcare workers, and I know also you in REACT Africa do that. We were together at a hospital last year in Lusaka, having sessions with the hospital staff from different departments of professions. And I know also that you have an interesting project called the SASPARS that were launched during the conference of REACT Africa last year. That is a little bit, it's quite different from the Strama, of course, but can you tell us a little about how are you working with the healthcare professional in that initiative?
Yeah. Thank you so much. I think it's important to understand that the healthcare system and the structure in African countries is very different from Sweden. But despite that, we don't have a primary healthcare system that is very strong, and it's actually quite weak. We've got really endemic challenges in hospitals, for example, where 1 in 3 hospitals there's no clean running water, and so issues around infections are quite large. So one of the things that we did was to study Strama, how really Sweden managed to be able to introduce a program that has had a lot of impact in terms of reduction of use of antibiotics, but also in terms of building capacity and being able to share the surveillance data that is being collected. So we thought that, we could actually leverage and start a program in Zambia called Zambia Strategic Program for Antibiotic Stewardship. And the cornerstones of the program in Zambia, slightly different from Sweden, is that initially we wanted to focus just on the healthcare, at hospitals and clinics, but then the animal sector and the environment, they felt that it was important that we are actually quite inclusive in addressing that. So we have taken, we have had a number of actually engagement meetings with the professional bodies. We have been able to present in hospitals. We are piloting stewardship programs in 9 hospitals directly, and we are actually promoting both a top-down approach and a bottom-up approach. And so really ensuring that at provincial level, that we start actually convening meetings of doctors, and other allied professionals that are working in the health sector to actually have conversations on what they are seeing and really building that capacity that is required for stewardship. And so we've got those building blocks. The goal is to ensure that that stewardship begins at the lowest level of hospitals up to the tertiary level institutions we have in the country. Thank you.
Thank you, Murphin. And then over to you, Malin. I mean, you've spent like the last year actually talking about exchanging with other countries and other governments, both like on awareness raising about the problem, I guess, but also exchanging on like ways of working. But first of all, I would like to tell us a little bit, I mean, because the Swedish way of working, if we put it that way, that's much more than only stewardship and the healthcare sector. Can you just tell us here in the audience, what is it that we do in Sweden? How are we working with AMR or antibiotic resistance?
Thank you, Anna. That's, of course, a huge question. So I'm not sure we have time to talk about it all. But I think what you're after is really how we also work in coordinating the cross-sectoral work, right? So in Sweden, we do have an overarching strategy, national strategy for AMR, and then the implementation is really made by mostly governmental agencies, of course, and then, of course, very much on the floor in the healthcare system, in the veterinary healthcare, on the ground, really. So, but if we look at the national level, this coordination is composed by a group of 23 different national governmental agencies, and in addition to this, a few other strong stakeholders, such as REACT, such as Strama. And this is really, when we talk about One Health sometimes, that is kind of the buzzwords in this area, and also in pandemic prevention and preparedness and response, of course. When we talk about One Health, it's very often limited to where infections or resistance spreads between humans, animals, and the environment. But if we really talk about the multi-sectoral approach, then we need to have many other sectors involved as well. And this coordination group is really composed also by agencies, not only from the 3, but also, for example, education, research, trade, development cooperation, for example. So it's much broader. Then again, of course, coordinating 23 agencies and then what they do out in the society. That's not the easiest thing, but they do come together. They have their own plan, their work plan, the action plan, which is closely monitored and followed up all the time. So I think it's something that's been working very well for Sweden. It's taken a lot of time, of course, to come where we are today. But if we look at the Swedish experience, of course, it started very early. So we're fortunate enough, and part of the Swedish success is, of course, that we started early. Our first national action plan was published already in the year 2000, and it was already then including both animal and human sector.
Yeah. And I mean, today is the last day of Sweden's presidency, so soon you and your colleagues will have a little bit more calm summer than up to now. But also, like within the EU, there are big differences with it, how far you come and what you focus on. But you also, like, you exchange much more also like also beyond EU and with many other different. But when you then talk with representatives from other countries, what is it, any specific thing in the Swedish way of working that you think like, okay, this is what you like, what we could export, or is it from their side that they're interested in? Is it the Strama, or is it something else, or is it just the way that you described it, the integration?
I would say both. I mean, sometimes you just get the question, right? What does Sweden do? How come you're so successful? And I think then it's really important also to take this step back and see that, okay, we started in year 2000. We're also, we should be really humble and understand that we started from a situation, we're a country where we have already clean water, we have sanitation, we have access to healthcare, we can actually have antibiotics prescribed by medical professionals based on diagnostics. So it depends on who you talk to, right? But I think there's definitely some of these experiences that could be really useful as long as we adapt them to other contexts. And I would say partly, yes, this way of working across sectors raises a lot of interest because it's not easy. We're struggling, of course. But we found a model that is working for us. And if that could be adapted to other countries, we think that's an experience that could be used. The other aspect, and this brings us back to Strama, right? Because Strama that's a famous concept in the world around us. And I think that is something to be really, really proud of. Then, of course, it's not obvious to everyone what Strama is, but and some of the elements are probably quite specific for Sweden. We have quite flat organizations. The Strama work often involves many different professional groups. And of course, in more hierarchical context, it's quite difficult to put nurses, pharmacists, and infectious disease specialists in the same room and say that, okay, now you're in this together, solve it. So of course you have to find your ways. But I think one of the strongest aspects of Strama and part of the success is the use of data. Right, so we use the prescribing data, put it on the table, and look at the adherence to treatment guidelines, look at the actual prescribing, and then you can have a discussion. So I think also still, even in more hierarchical systems, you can still have this peer-to-peer discussion. Learn from each other, and also, the use of the data is also a type of benchmarking. So that's another aspect that we're used to transparent systems. We publish the data, the prescribing data, the resistance data openly, updating every month. And this is, of course, a way of also comparing between the different parts of Sweden, for example.
And is that then something that is unique to Sweden? Or are other countries having similar things, the Strama, but not exactly the Strama? Or is this like just the peer review and also the sharing of data and using the data like on healthcare structural level? That is really like...
I think it's kind of unique, and at least it's unique that we started this early, and also unique, as Thomas was mentioning, that it really started as a grassroots movement. Of course, many countries have also now developed their own systems and ways of working, and some of this is similar to the Strama work. But no, I think it's kind of unique, and again, if adapted to a country's context, I think quite useful.
And Thomas, I think Strama, you also have exchange with, like medical associations and other groups. Do you experience the same thing, that we are like, this is really something that others are interested in piloting and implementing?
Yes, I do think so. And like Malin also said, it's quite unique, I think, to have a network that is so flat, where we actually work together across disciplines. And what I still think is quite unique, also compared to other countries in Europe, is that we work also both in primary care setting and hospital setting. So in many countries, these parts are divided, but we have the same antibiotics, so we should work together on this. So I think it's very well integrated everywhere in healthcare. So that's a key point. And people are aware of strama for sure. They're not quite informed about exactly what strama is, but they see the prescribing patterns. They see that we have successfully reduced prescriptions a lot in the past decades. So there's definitely an interest.
And then I just can take the opportunity to say that the e-learning then, that is up and running now, and you can find it on the webpage of Folkhälsomyndigheten. But also, like for the international audience, one way to access is actually to go to React's homepage and just click on the news box on the strama education, and that is a quite good package. Can you say a couple of words what's in there and what we aim to do with this e-learning module?
Sure. So we developed this course to inform two different target groups. So the first one is like anyone who's interested in understanding the problem of resistance and what we can do about it. And this also includes politicians and decision makers, of course. But then there are some chapters that are really technical and detailed. And there we focus on or target professionals who already know a lot about antimicrobial stewardship. And we try to describe in as much detail as possible how we actually extract data, how we provide feedback to prescribers, how we educate them, awareness raising in the community. So there's a lot of information there for those who are really interested. But just to be clear, and as Murfin also mentioned before, it's not possible, of course, to just take these tools and copy paste to other countries. What we try to do is to better explain what strama is actually doing, because this information has not been available in English before in such a dense format. So we describe that and we leave to others to decide which parts can be used in their context.
And Jakob, you have worked in Jönköping then, being, in this, not maybe in strama itself, but clearly like in your hospital you work with implementing these things. And then like having Tansen Hospital in mind, what do you think, like from the strama work that do you think could be like most relevant to extract or implement at any specific thing? It's like if you give you 2 more years there together with the team there in place would be good to use.
Yeah, there are many challenges in implementing it. I think it might be possible definitely to implement parts of it. But it needs to adapt according to the context. In, for instance, Nepal, just as already mentioned, just a few challenges would be that patients are traveling very far to healthcare. They might have taken antibiotics before, which is making the clinical picture a bit more unclear. And complications from, for instance, streptococcal infections are different there. Rheumatic fever, rheumatic heart disease, kidney disease than we see here. So that's a few points where I think adaptation would be necessary. I think one main thing would be that we need local data on resistance in the community-acquired infections, because in Nepal, many times the studies you read might be from the tertiary centers, the big university hospitals, and then the patient might already have taken antibiotics once or twice, and when it doesn't work, then they come there, and then we take a test, a culture from the bacteria, and then of course they are very resistant, and it doesn't really mean that the community-acquired bacteria look really like the data we get from there. So local data from the microbiology labs would be essential, I think.
And how about like involving healthcare workers, creating groups locally? Would that be also something that could be interesting to?
Yes, absolutely. And when we have local resistancy data in place, I think it's very good to sit down between departments and discuss how are we treating the infections in our own setting. Yes. And
over to you, Murfin. I think similar kind of workshops months together with staff, looking at the situation, you've already like doing that in I think in a couple of places where you work. Is it similar to the Swedish way of working, or is it a quite different way of exchanging? And I know also that access to data is one of your big challenges as well. And you need to unmute, I think. Yes. Can we hear you now, Merfin? It's in the room we don't hear you, Merfin, but maybe online. I think we don't hear Merfin. I'm just checking with no. Thomas, can you hear us, and can you try to speak on your mic?
I can hear you.
Yes. Okay. We'll see if we can get the sound to work with Merfin again, but then I'll move over to you with one other question that I hope that Merfin can hear and answer to in a little bit. Yes, because like when we in REACT talk about also like, okay, the importance of working with a stewardship, and when I exchange with colleagues here in Sweden, we talk much about, you have the medicines, you have the antibiotics on the shelf, and you need to use them rationally. But in many other places where the REACT colleagues work, and when, previously when I worked with Médecins Sans Frontières, that the problem was really that the antibiotics were not on the shelf in the healthcare structures, and also like you did not have even if you wanted to prescribe the right thing, as you said, then it wasn't possible. So, and I think like from Uppsala University and Platenea, you're quite involved in this problem also being the reality in the Swedish healthcare systems today. And there was a seminar on this 2 days ago here in Almedalen. What do you think, in terms of that work on a global level, from Platenea and from Sweden, how can we address this challenge of actually not getting access to antibiotics that is needed?
I think it depends on what level you want to work. So if we could first look at Sweden, and to ensure we have all the antibiotics we need. And we already have problems there because we have experienced, like you said, more and more shortages of even common antibiotics that are used for very common infections. So obviously that links back to a fragile system, very few producers, very few providers, which is very susceptible to disturbances. So the underlying problem is for sure global, but we do have local problems. We could work with securing access locally, or in the Nordic countries, we could work with stockpiling and things like that. But of course, we need to move abroad in this problem. So working at the EU level already make the opportunities a bit more extensive. So there are a lot of initiatives ongoing there to see how we can prevent shortages, and also more in clinical practice deal with shortages, find alternative treatment recommendations, save the remaining doses for the most patients who are most in need, things like that. But like you said, it's a very old problem. It has been or is still very much an everyday problem in low-income settings. So it's just, I would say, the past 5 or 10 years that we experience more problems also in Sweden and other high-income countries. So this is a huge issue. I think it's important to point out that shortages will cause the same problem as resistance. In the end, you don't have the antibiotics you need to treat the patient. And if we have shortages, we will use other drugs that are not as effective or more toxic or associated with more resistance development. So it's really a big problem. And it's something that should be possible to solve.
Merfin, let's see if you're back. Yes, we hear you. So now you can choose if you want to talk about the local stewardship work, or maybe address the question on shortages, because I know this is something that you're quite engaged in.
Yeah. So I think the earlier this combines well with the earlier question on what are some of the things or some of the lessons that are working. Yes, really engaging with the professional bodies for us has been a great key. Just last week, we were, presenting at the National Pharmaceutical Society of Zambia's annual general meeting, and the focus was on AMR. And so we really took time to talk about really stewardship using local data that is available in Zambia. The fact that, we also work in hospitals where we are able to generate that sort of actually data and can have conversations is key. But, stewardship generally gets challenged, and even models like Strama get challenged when you don't have lab consumables available. You are always out of stock, so you are unable to identify any pathogen or try and do really any antibiotics sensitivity testing or susceptibility testing. But also when you chronically have today, lots of stockouts of basic antibiotics, then it challenges your stewardship, because in as much as your guidelines might be able to say, this is your first line of treatment, if it's not in the pharmacy, you are completely out of, that becomes a challenge. Or reverse-wise, you don't have any guidelines in an institution, which is something that we have also done in Strama, has been to actually develop guidelines, local guidelines at the University Teaching Hospital, and using that local data and creating an app for it to increase access for the clinicians to actually use. So, those basic building blocks need to be in place. And when we talk about actually stockouts, it's really sad that we're talking about basic molecules, really, ampicillin, it's amicepro, ceftriaxone, metronidazole. These are basic molecules that every healthcare setting should have. But if you don't have them, and we've done lots of research looking at the African hospitals, what are the 10 most antibiotics that are out of stock? It's the same one, country from country. So, those are issues that definitely challenge really, a good implementation of stewardship programs.
Thank you, Murfin. And now I think we can have the time now for one or two questions from the audience. And while we do that, the panel can think of, if you have, two things you'd like to happen, either towards the high-level meeting or in your field of work. If there was some priorities and, action points for the future. Or if there's something you wanted to say that you didn't have time to say yet. So you can think of that while we look out and see if there's questions in the audience.
Hello, good morning everyone. Thank you for your contribution so far, very interesting. I would like to share an example from one of my travels in Africa a few years ago. I was traveling in Ethiopia and I was a bit shocked there by the situation where it wasn't a shortage, it was more or less the opposite, like last resort antibiotics that were sold in an over-the-counter setting. Patients that were complaining about a cold or a cough would get like cephalosporins or something else. So how is that being managed on the ground? So, Murfin, that question to you, I heard you mention Zambia a couple of times, but how are we working with educating local healthcare professionals, the general public, perhaps, to use these products in a correct way?
Thank you for questions, and maybe also regulations, adding on to that. Murfin, do you want to...
Yes, absolutely. We have created lots of education opportunities across the African region. We do this through, online courses that we have. We also have actually physical meetings in different countries, in Kenya, Ghana, in Nigeria. But we also have, published literature and messages that are really targeted to clinicians, very specific for clinicians, very specific for actually politicians, very specific for actually supply chain, managers and those working in that aspect. Yeah, and I think the point, your observation that you made, I think is important, is that yes, whereas in some countries we still have a challenge in terms of having last resort really antibiotics on the market being sold. In other places, it's actually larger. It's a lack of access, but very fewer molecules that more than the critical ones. They mask the picture to show as though there is actually excess. Well, in the true sense, there is a lot of lack of access as a major issue. Thank you.
Thank you so much. Do we have other questions in the audience? I think this what you raised about public awareness and also like what the individual choices in healthcare seeking behaviors and all that is quite important in all countries, as you say. I guess that could maybe be a way of working also more in Nepal, and we try to do it in Sweden as well. Well, I think we can start the last round, and I look at Malin first because you like me. What do you need?
What do I need? Well, you've already touched upon it, and that is public awareness, right? I think that we very often, when we talk about this, we talk about it as a problem that people would know about. And I think also right now we're talking to the kind of already convinced. The people listening to this are already concerned with antibiotic resistance as a health threat and a threat to economy, to food security. So this is one thing, of course, a more general understanding to see this. It's a sustainability issue, it's an equity issue, it's a development issue, and it affects our entire society, and it affects every individual. All of us could suffer from an untreatable infection, right? So it concerns us all. So beyond what I talked about before, a more whole of government approach, we also need a whole of society approach. I want everyone involved, and that in itself would of course also support a more appropriate behavior. If you are really concerned and feel that this is something that you should worry about, then you wouldn't of course demand antibiotics from your prescriber or buy it over the counter unless you were sure that you actually need it according to a diagnosis. So that's one thing. I think the other thing, because we talked now about implementation of national action plans, and Murphy explained how you've been able to support many countries in developing their national action plans. And you talked about Nepal, and they have actually implemented a lot of the activities within the national action plans. But all of us, all countries, regardless of where we are, also Sweden, need to do more. It looks like we are gaining some kind of momentum, I believe. But I mean, the current pace is just not enough. Of course, you have to be humble. You understand that this takes time. This Swedish National Action Plan that I talked about from the year 2000, we have goals in there that we still haven't met. So, of course, you need to understand that it demands systems transformations. But to implement action plans, you have to have allocated budget for this. And that goes for all countries. And you have to have some kind of monitoring and following up. And this is like my final expectation now for if you want to hear what we hope for or what we wish for. And that is, I think, for this high-level meeting in the UN General Assembly, all the world's countries will come together. And I think it's going to be really important to also set concrete and measurable targets and assure that we have a mechanism to follow up the implementation. And very briefly, as you mentioned, the Swedish presidency of the Council of the EU, 2 weeks ago, we managed to conclude under our presidency the adoption of Council recommendations, which is a legal instrument for all the 27 EU member states, where all these countries actually agreed on specific targets on a reduction of both use of antibiotics and reduction of resistance in itself. So I think it's really encouraging. I was really happy to see how the willingness and the cooperation of the countries in these negotiations that we were leading, it was a really positive experience. So this gives me hope for the future and for the UN General Assembly. I do understand that the EU is quite different from UN and from all the countries in the world, but still, I think maybe the time is actually mature for this now.
And what also came out quite strongly was EU's role in the global picture, and also like working together with low and middle income countries to address the problems where there's more challenges also to changing systems. Yeah. So that was another very important outcome. Jakob, briefly, like 2 things that you'd like to see either for Tanzan hospitals or in general when it comes to improving in this stewardship or with EMA.
I think no change for the future will be lasting and effective unless over-the-counter antibiotics sale is regulated in a country like Nepal. We have touched upon a few other things. Microbiology lab capacity building, better guidelines, public awareness. But one more thing that I'm thinking of is new inventions. We would need new diagnostic tests, inexpensive, rapid, high quality, we have seen the effect of such tests. For example, when I worked in the dengue epidemic, dengue virus, to diagnose the dengue virus during last year's epidemic in Nepal. And it's a very powerful tool. And I think that would be one wish for the future as well. Yeah.
Good. Clear and very achievable, maybe. Yeah. Murfin, you, two things.
I think one of the things that would like to see is that there is a larger focus and larger support in prevention interventions at community level. The focus needs not only to be on health institutions, but we need to prevent infections in communities. We need to ensure that those health determinants of health, like clean running water, is available in communities. We're living in a world in which 600 million people have no access to clean water and sanitation. 1 in 8 people defecate really outside. 1 in every 5 children who dies, they die from preventable causes. And so we need to focus on that. And then secondly, we need to ensure that we maintain the momentum and the small gains, and we work together as a global community. We are only as strong as the weakest link and the weakest country that's there. Thank you.
Thank you very much, Murfin, for that complimentary 2 points. And Thomas, over to you. What do you think is the most important 2 ways or wishes that you have?
Yeah, so first I just wanted to say in relation to the e-learning course that it's just been released, and we'd be interested in any feedback we can get from other countries to see how this can be useful. The course is free, so please check it out and let me know what you think. And then, of course, we need to work globally on finding new antibiotics and availability and rational use also of the existing antibiotics, and also diagnostic tools is definitely an important piece in this. We need to challenge the business models, which obviously don't work for antibiotics. These are really difficult questions, but we need to tackle those as well. And then finally, on a national level, my biggest concern would be that we take Strama for granted. We need to ensure continued resources for the regional groups, which are really the core of our antimicrobial stewardship work in Sweden, and the work will never be done. Thank you.
Thank you. And I know there's a couple of more people who'd like to come in from the audience, but instead I think I can ask the panel to stay on in the room after, so we can have a dialogue. And for the other people online, I mean, you can always reach out to react to Strama, look at the course, also like engage with Uppsala Antibiotic Center. And we are, I mean, I think we touched upon, and Murphy said it well, like not stronger than our weakest link. So this is really about exchanging and learning from each other. And I think this was a great opportunity actually to do a small reality check on the Swedish ways of working, and also thinking out, you know, what will be the next steps to do. And we have 1 year until the high-level meeting, but actually quite much shorter to get to those strong commitments and targets, and to really mobilize all parts of societies in tackling this crisis. So thank you for everyone who participated today. Thank you to the panel, to the audience here, and to Uppsala University for hosting us here, and also to people online. And you can follow this seminar also afterwards. So thank you and have a nice afternoon.